All right, so welcome everyone to our monthly psychology grand rounds. Today we have the privilege of hearing Dr. Kseniia Gvozdieva. I think I'm closely saying that. Please correct me if I am not. Who's going to be talking to us about a topic, Catch Me If You Can, understanding and addressing patients' ambivalence toward treatment. Before I more formally introduce her, just a couple of housekeeping things. The link for CE attestation is going to be posted at some point during the lecture today in the chat. So if you're a psychologist, please look out for that. Otherwise, if you have any questions, please feel to type those into the question and answer section, and then those will be addressed toward the end of the talk. But now getting, to more formally know our speaker, Dr. Gvozdieva is an intensive outpatient program director at the Mount Sinai Behavioral Health Center and an assistant professor in the Department of Psychiatry at the Icahn School of Medicine here at Sinai. She obtained her master's degree in business administration with a specialization in management and economics from the National Transportation University in Ukraine. She earned her master's degree in mental health counseling and a doctoral degree in clinical psychology at City College. She completed her psychology internship and her postdoctoral research fellowship at Sinai. And in her clinical practice, Dr. Gvozdieva works with adults in individual, couples, family, and group modalities, utilizing an integrative approach to psychotherapy, drawing on relational psychodynamic tradition, dialectic behavior approach, as well as attachment and systems theories. That's a lot of really valuable stuff. She specializes in helping individuals affected by trauma, personality disorders, and substance use, as well as providing LGBTQ plus affirming care. And she's a certified group psychotherapist, has additional training in transference-focused psychotherapy, emotionally focused therapy, and alliance-focused training. And even more offers culturally sensitive services to Russian and Ukrainian speaking individuals in their native languages. So really a very talented colleague here. And so aside from clinical work, she also has a passion for teaching, supervision, and mentorship. And it is with great privilege that we have you here today to speak at our psychology grand rounds. And so it is all yours.
Thank you so much for the introduction. Let me start sharing my slide. All right. So thank you all for coming to my talk on ambivalence. So before we begin, I would like to make a few acknowledgements and let you know that I do not have any conflicts of interest to report, but I do owe a debt of gratitude to my colleagues, those who hold the other side of the dialectic and pull me out of enactments, to theories, teachers, and supervisors for providing me with the framework I will be sharing with you today, and also to my patients who help me with continued education about ambivalence and plenty of opportunities to recognize, understand, and address it in treatment. I find it helpful to have clinical examples in mind when we talk about clinically relevant things. And so perhaps to help you think of some folks who you treat, I will give you some ideas on how ambivalence might look in treatment. So it might present itself at any point in treatment. At the treatment initiation, there might be signs of a patient coming in with a very strong desire or maybe even great urgency.
I don't mean to interrupt you. Your mic is very fuzzy.
Okay, let me try it again.
Okay. Sorry, I just want to make sure everyone can hear everything that you're saying.
How about now?
Sounds a little bit better.
Excellent. All right. All right. So sorry for the interruption. So as I was mentioning, that The signs of ambivalence might be present at any point of treatment. At the initiation of treatment, which we might see is
Kseniia, sorry, we really can't hear you.
okay, let me
I
just.
should have done a little bit more of a sound check. Apologies to everyone. Hold, please.
Yeah, what's going on? Let me switch it.
No, we don't hear you at all. Nope. Not sure if it's possible for you to use the computer microphone instead of your headphones, or if
Yeah,
that would be any better.
well, can you hear me now with the
Yes,
camera?
can you say, just say testing 1, 2, 3?
Testing 1, 2, 3.
I think that's better. Yep, that's the best we've heard
Okay.
so far. So let's
Yeah,
try that.
excellent. All right. Not beautiful. Okay. So I guess my tech is rather ambivalent about my talk. So what you can see a patient do if they're ambivalent is that they might be presenting with a great urgency to begin treatment, but then suddenly begin to act as if the treatment is of no value to them. So their initiation of treatment might be precipitated by an event of clinical significance. It might be hospitalization, maybe some breakdown of their habitual coping strategies, some loss or major stressor. And once they are in treatment, they might begin to minimize the significance of the event, minimize the severity of their symptoms, and also begin to miss or cancel appointments. Or engage in other behaviors that interfere with treatment progress that can also be seen in an ongoing treatment and close to treatment termination. In ongoing treatment, ambivalence might be precipitated by positive developments in treatment, things like new insights, or negative developments in treatment, any kind of termination, or maybe emergence of symptoms after a period of suppression or dissociation of symptoms. This kind of idea that they might get worse in treatment before they get better. With the termination, it's often when the termination is introduced or when the treatment is approaching termination. And the types of treatment interfering behaviors that might be seen, the sign of ambivalence is usually a mixed message between verbal and nonverbal communication, and we can also experience it in the countertransference. So the type of countertransference that is consistent with ambivalence is this experience of running in place. Things are not moving. We might feel stuck. We might get frustrated or bored, maybe even resentful, hopeless, or inadequate. Behaviors to look out for is when the patient uses session time to talk about, say, clinician or various trivial events with very little emotional contact, kind of the small talk or storytelling pattern. They might also focus on other people's behavior to the exclusion of their own internal and external responses, therefore inviting the therapist to do therapy by proxy. It also might be that they introduce some concrete life challenges, crises du jour, to enlist clinicians' help while they themselves are not engaging in enough motivation or effort to address the challenge outside of sessions. It might also be the kind of pattern of seeking help rejecting behavior in which the patient might be asking for treatment alternatives while simultaneously underutilizing the treatment that they already have in place. Or if the new treatment is offered, they might report that it's somehow inadequate or failed them. Other signs of ambivalent behavior is increased contact out of session, kind of treating their clinician as a hotline of sorts, in which there is communication via phone or email while at the same time in-session communication is unproductive, or the sessions are missed or canceled when they're scheduled. And finally, the pattern of navel gazing in which the patient is engaged in deep self-exploration, develops increased insight over time, so it gives us a perception of them working hard in therapy. However, that insight does not translate to any observable progress outside of the session to help them bring closer their treatment goals. And so our responses to patients' ambivalent behavior might lead us into the unethical territory of boundary crossings and violations. So, for example, engaging in social communication with the patient might result in us developing a friendship-like relationship with the patient, or even a romantic one. Focusing on other people might lead us to render opinion or judgment about the third party, including our colleagues, based on the patient's report, or even assigning a diagnosis to a third party without ever meeting with them or interviewing them. If we are focused on patients' life problems, we might get into an area of resolving their life issues on their behalf, even though they have the capability of doing so themselves. Focusing on various treatment alternatives might result in us offering them treatment that may not be clinically indicated while being under pressure. Between session contact might result in us excessively rescheduling, meeting outside of our regular hours, extending session time, or even providing services without compensation or documentation. Say we have an hour-long conversation with the patient on the phone, which feels like a therapy session. However, it is not scheduled or documented or billed. Additionally, insight without progress might lead to us maintaining patient in treatment for a prolonged period of time without significant progress, or even progressive deterioration of patient in the session, or fostering dependency on the clinician rather than encouraging their growing autonomy over time. So now that we have an idea of what ambivalence look like clinically and what might be the pitfalls of it, I would like to talk a little more about how to understand ambivalence from the psychological standpoint. So the definition of ambivalence per Merriam-Webster is that it's a simultaneous and contradictory attitudes or feelings, such as attraction and repulsion toward an object, person, or action. Basically, it's wanting to have it both ways. And the three ways ambivalence presents itself, it might be integrated, split, or resolved. Integrated ambivalence results in being able to hold both experiences in mind simultaneously and compromise effectively. Ambivalence that has the potential to interfere with treatment is most consistent with the defensive process of splitting. And splitting is often called black and white thinking, all or nothing thinking. And it's a separation of experiences into all good and all bad categories due to one's inability to resolve the contradiction between the two. And it's important to understand that being able to resolve those dichotomies is a developmental achievement. And if we are unable to reconcile good qualities of the object with the bad ones, the process might become defensive as a way of protecting the good part from being contaminated by the bad. It is rather common for folks with complex trauma history because at some point in life, they experience their caregiver as simultaneously hurtful to them while dependent on that caregiver for survival. And so obviously those two things are difficult to reconcile. What is not splitting is ambivalence that is resolved either in favor of withdrawing from treatment or in favor of fully engaging in treatment. So patient being lost to contact means that they're consistently disengaged, as opposed to them being engaged in treatment just enough to remain connected to their care. Patient decline in services is also ambivalence that is resolved in favor of withdrawing. And alternatively, patient complying with the treatment plan, the parameters of treatment, using the session time productively, using their treatment to help them improve their life outside the session, and making consistent progress towards one's goals is ambivalence that is resolved in favor of full engagement. And so what I would like to focus on going forward is how to help one move, help one's patient move from this split part to more integrated or resolved state. As we're speaking about splitting, it might be helpful to think about splitting as related to diagnostic categories. So I'm usually thinking from a psychodynamic or object relations perspective. I'm happy to talk about connection to other theories or therapy approaches in the Q&A if folks are interested. But from the psychodynamic perspective, we all operate at some point on a range of functioning, from the most organized to the least organized level of psychological development. So the normal level of psychic organization is the outcome of treatment, because complete psychological health is truly an accomplishment and may not even exist, hence the quotes, because we all have our blind spot, despite all the treatment we might have. Being in a neurotic level of organization allows us to express our ambivalence verbally and grapple with it in treatment in a conscious way. In that case, ambivalence does not interfere in participation in or productive use of treatment, because it does not interfere with one's ability to talk about their conflict with their clinician. I will go out of order here because I'd like to talk about the borderline level of organization last. So the psychotic level of organization usually presents with lack of ambivalence due to impaired decision-making. Folks who are experiencing psychosis might not feel the need for treatment, and therefore they might require involuntary treatment until their reality testing is regained and they're able to understand the impact of their illness. Folks in the borderline level of organization use splitting as their most common characteristic defense, and in which the two sides of the conflict are dissociated. So the side of them that wishes to be in treatment is dissociated from the part of them that does not. And the way it might manifest is that they might want to be in treatment in concept, but not in actuality. And therefore, they might engage in those avoidant tactics that are not experienced by them as intentional withdrawal from treatment. What might be helpful to consider for the differential diagnosis between the borderline and neurotic level organization in particular is whether this ambivalence is a chronic problem for them. So if it has more to do with their characterological presentation. What to look out for is history of multiple aborted treatments, instability in work or relationships, instability of life goals, instability of sense of self, and their unawareness of their ambivalence. So it feels as if it's just the way they are. If ambivalence is more of a unique scenario for this patient, might have to do with, a true situational influence, such as, I don't know, global pandemic, for example, then ambivalence is really not for the lack of trying. They're conscious of it, they're able to speak about it, and it's not something that is realistically in their control. Another thing to think about is how folks respond to any evidence of ambivalence being brought to their attention. If they become reflective and curious, that suggests more of a neurotic level of organization. If they act in a way that is shameful or excessively acquiescent, or alternatively frustrated and oppositional, that suggests the presence of splitting. And we'll talk some more as to why those would be the two ways that one might respond emotionally. So continuing to think about ambivalence as splitting, and again, splitting is this defensive operation that serves emotional regulation by keeping all good and all bad parts disconnected, both in oneself and in one's experience of another. The two parts that are disconnected, the all good and all bad, are corresponding to the drives of libido and aggression. When those two when those all good, all bad libido and aggression parts are disconnected, they are by definition not modulated by one another. And so they're kept apart in the service of the good remaining good so that it's not contaminated by the bad. But the unfortunate consequence is that the bad is therefore not modulated by the good either. And so Henry Longfellow once wrote, there was a little girl who had a little curl right in the middle of her forehead. When she was good, she was very good indeed. But when she was bad, she was horrid. And drive means that both libido and aggression provide access to energy that can be used productively or not so productively. So libido, the all good part of the split, is connected to the emotion of love and care. The benefits of being connected to that energy is that it provides access to closeness and intimacy with others. However, if it's unmodulated by aggression, it might lead to enmeshment and dependency. Aggression, the all bad side of the split, is connected to the emotion of anger. The downside of unmodulated anger is that it can result in abuse or neglect. The benefits of having access to aggression is that it provides access to feelings of assertiveness, initiative, self-directedness, and helps us with being autonomous. So ambivalent folks are dealing with the push and pull dilemma between leave-in treatment or staying in treatment. And both of those parts come with a particular wish and fear dilemma. So staying in treatment is connected to the wish for care and relief from suffering, but at the same time, there's a fear of change, fear of effort that is required, fear of some painful insights, and fear of dependence on potentially incompetent and malevolent other. The other side of the dilemma, leaving, comes with the wish for immediate resolution of tension or challenge, so-called flight into health. And there's also fear of losing treatment and support, losing progress, having another crisis without being able to rely on treatment for support, and also the fear of feeling guilty or responsible for ending the treatment relationship. And so avoidance is an emotion regulation strategy, and ambivalence is avoidance of commitment to one of the alternatives because it's so hard to let go of one or the other. And as clinicians and humans, we also might find ourselves on one or the other side of that split. And when more than one person is involved in treatment, we might also find ourselves in opposition to other members of the treatment staff, in which case the staff aligns along the all bad and all good sides. So I will speak some more about what it might look and feel like. So for those who side with the patient's engagement, the motto is to meet the patient where they're at and focus on the part of them that is committed to treatment. So siding with the libido and being on the all good side, we pay little to no attention to evidence of ambivalence. Things like missed sessions, rejection of viable treatment options, maybe lack of effort outside the sessions, or engagement in other treatment interferent behaviors that I mentioned earlier. The benefits of being on the all good side is that it's pleasant, it's mutually satisfying on the surface, and so it might be rather seductive. Clinician feels useful, special to the patient. They may even feel superior in their goodness in comparison to other clinicians who view the patient in more negative terms. And patient, on the other hand, feels attended to and helped and also special, maybe even favorite. They may feel that they finally found the perfect provider for themselves, someone who truly understands and accepts them as they are. The downsides of being on the good side of the split is that patients needing special accommodations supports the idea of them as being impaired, reinforces their identity as a patient. And that might be, despite evidence of their consistent engagement in educational pursuits or employment, it might reinforce their dependency on the treatment or the clinician. It also can make it difficult for the patient to express their aggression in treatment, despite it manifesting in their other relationships or it being self-directed by non-suicidal self-injury or suicidal ideation or even suicide attempts. In the long run, siding with the good side of the split leads to an unproductive treatment, or maybe even a negative therapeutic reaction in which the patient becomes progressively more symptomatic or exhibits various treatment interferent behaviors, which leads to clinicians eventually feeling burnt out, resentful, ineffective. They might begin to question their skill set due to lack of progress despite their best efforts to help. And patients, based on their life experiences, they also recognize the dynamic as too good to be true. We know from fairy tales that if there is a gingerbread house in the middle of the woods, it's most likely occupied by a cannibalistic witch. And so the patient becomes understandably suspicious and begins to test the limits by becoming more demanding as a way to make the second shoe to drop already. They also might become dependent on clinicians' validation and over time grow resentful about clinicians being the ones they're trying so hard to please. They might grow envious of clinicians' competence or generosity, which is in comparison to their own negative self-image. And so they might engage in treatment interference or even self-destructive acts to prove to the clinician that they're fallible. Alternatively, they might see clinicians as trying too hard and therefore being needy, sensitive to rejection. And so the patient feels that they cannot tell the clinician directly when they want out, and instead they ghost the clinician to avoid those uncomfortable conversations. The alternative is to side with the patient's avoidance. So the attitude there is one strike and you're out, and the focus is only on the behaviors of the patient that are not consistent with engagement and treatment. So that siding with the aggression, all bad, is connected to paying no attention to patients' efforts to engage in treatment, however minimal those are, including showing up just enough to remain in treatment, or being willing to make use of at least one modality of treatment, be it med management or group or individual treatment. As rather obvious, this is not as pleasant a place to be as compared to the all good side of the split. And also aggression is often much less acceptable in oneself for those of us who are in the helping profession. And so it's often avoided or denied while libido is normalized. Sometimes siding with the bad side of the split is the result of being on the good side and burning out. So there are benefits and downsides to both. The benefits of siding with aggression and getting rid of the patient is that it eliminates the tension of contemplation. It forces an immediate resolution, so there is no uncertainty. Clinician might feel relieved of the burden of barely compliant patient. They're able to move on, focus on more satisfying treatments. They might even feel vindicated in getting back at the patient who devalued what they had to offer. Patient on their end might feel relief of pressure to comply with treatment parameters or to exert effort to bring about change in their lives. They also avoided shame or guilt of looking into their own behavior and how it affects others. And they also might feel the self-righteous, I knew it stance in which they're affirmed in their negative devaluation of the clinician who abandoned them or did not understand them. The downsides on being on the all bad side of the split is that treatment might be prematurely aborted. It is a missed opportunity for a new relational experience and a new insight for the patient into how such dynamics are repeatedly co-constructed by them. The downsides for clinician is that they feel devalued by patient for being rejected and critical. They feel ineffective due to high patient turnover. Perhaps they feel some dissonance with their internal value system as a clinician. They may enter a conflict with colleagues or feel insecure when comparing themselves to those who are on the good side and are idealized by the patient. The downsides for the patient is that they feel rejected and abandoned in time of distress. They accumulate additional evidence confirming their fears of being untreatable, unworthy, and easily discarded. They also might view clinicians as unavailable for connection, uncaring, cold, rejecting, and that can have implications for them seeking help in the future. Alternatively, they might be reaffirmed in their belief that the problem is external to them, and what they need is just keep looking for the right provider for themselves. Or it might not only be a provider, but also partner, job, program, hospital, and so forth, which leads to unproductive allocation of their efforts, which could have otherwise been spent on working on themselves. So the reconciliation of the two sides would be perhaps an unpopular opinion that both libido and aggression are important and equally valuable. And this is despite that as helping professions, we're often being associated with the former, but not the latter. But what I would like to argue is that if we are to help someone integrate their disparate parts, we must first be able to integrate our own and walk that walk and practice what we preach. Do as I say and not as I do rarely works. And our patients pay attention. So it's best to teach them not in word, but in our action. And so being willing to act imperfect and assert ourselves would free them from comparing themselves to the ideal other, and also demonstrate to them that to be good enough, we don't have to deny our aggressive impulses, but it models how to express this powerful and potentially dangerous emotion in a measured and controlled way. It also allows them to see us as more authentic and therefore much more trustworthy. Sometimes it's our own discomfort with conflict or imperfection that leads to our avoidance of frank discussions of ambivalent behavior with our patients. And so in a way, we join them in that fear when they fear self-assertion and we fear acknowledging the obvious, that they're halfway in and halfway out. And the process of catching ourselves when we lean either way, whether into, the love and caring libidinal side or the angry aggressive side, is similar to walking the tightrope. And if we engage in that process, it also provides us with empathy for our patients, because it reminds us that ambivalence is a part of human condition. We all want all the things all at once, and it's normal. Additionally, as far as empathy is concerned, it's important to recognize that enactments are inevitable. And so in any relationship that is real, two parties affect one another, including clinicians and patients. And when it happens that we play into one or the other side, it's simply an opportunity for us to step out, examine what happened, learn something new about the patient's way of relating to others, and also our own contribution to any interpersonal dynamics we enter. And we get better at that with practice. There is improvement in how easy it is for us to recognize and resolve that. Supervision or consultation can be invaluable in catching ourselves, because the third party has the benefit of perspective. And especially if you have someone you are not seeing eye to eye, that person is an invaluable resource, because they're seeing right into our blind spots. And therefore sharing information helps us see a fuller picture. It's important to recognize our defensiveness when we hear other folks talk about things we may not recognize within ourselves. Defensiveness gets in the way of collaboration and acceptance of influence from one's colleagues, supervisors, and even patients. And so if we find ourselves struggling with the feedback, it simply means that it's something new for us to learn, something we don't know yet. We don't yet know about ourselves, so we should probably pay more attention to that. Additionally, our unhealed parts, our personal tendencies might contribute to getting caught in particular enactments. So for folks in helping professions, compulsive caretaking might be a thing, and it is also reinforced by the notion of patients being impaired, which leads us to the all good side of the split. On the other hand, burnout and cynicism makes it more likely that we see patients as all bad. It's important to acknowledge our own agenda as well. Is this important to us that patients stay in treatment with us? Or is it possible for us to act impartial and okay with not being needed by them, or not being able to help someone who is not ready or willing to accept help, or for someone what we have to offer is not a good match. Or alternatively, is it that we're hoping to reduce our caseload, we're looking for reasons to discharge, or are we willing to put in some effort to identify treatment options that actually might work for this patient? It might be, drop-in services, less frequent appointments. It depends on the treatment, of course. And us paying attention to our countertransference in similar terms as I discussed earlier is whether it's characteristic or unique to the situation or the patient. So if countertransference is characteristic, it usually has to do with our own preference for either togetherness or separateness or vice versa. So the solution for that would be for us to self-correct, knowing where we lean, and also seek those who are complementary to us so that they can balance us and help us find our way towards the middle. If our countertransference is more unique to the patient or the situation, it is likely either information about how they might feel about us or how other people in their lives often feel about them. And so we can use our experience with the patient to inform our intervention and have a fuller picture of what they're like. So I would now like to talk about the intervention. So therapeutic neutrality is a rather global intervention. It's a therapeutic stance that we can use in all of our treatments. Therapeutic neutrality means that the role of a therapist is that of a collaborator and a process consultant. So we're neither omniscient and all-powerful, nor are we skilled and disengaged. We pay equal attention to verbal, nonverbal channels of communication, as well as countertransference. And being neutral doesn't mean that we're a blank slate. It means that we're acting in a way that is neutral with respect to the patient's dilemmas, but at the same time, we're curious, engaged, concerned, objective, and encourage their decision-making. Ambivalence is a symptom for folks with the borderline level of functioning because it's the splitting that gives rise to emotion dysregulation. And ambivalence is also a manifestation of their treatment goals because being able to merge the split will result in more stable affects, as well as a more stable sense of self and others. And so what we can help them see is that their ambivalence is not as unique of an experience to the treatment or the provider, but simply an extension of their way of managing their lives, various events in it, and relationships. And so rather than giving them fish and resolving their ambivalence for them, we can help them by using treatment to examine their ambivalence as a symptom and encourage their self-reflection as the path to its resolution, in a way teaching them how to fish so they can do it in their lives outside of treatment. When we highlight the behavioral manifestations of ambivalence, we reinforce the idea that all communication is meaningful, be it verbal or nonverbal, and also that their behavior or lack thereof has predictable consequences both in their lives and in their relationships with other people. And therefore, it returns the power they normally experience as coming from other people. They feel more empowered to own their decision-making, knowing that there are predictable causes and consequences. By remaining objective and not engaging in convincing them to stay or depriving them of treatment, but simply pointing out their dilemma of staying versus leaving, we can help them make a wise and informed choice by exploring all of the consequences of both alternatives. And similarly to any major life decision, as I mentioned before, it's a free choice. There are benefits and downsides, wishes and fears, either way. Additionally, therapeutic neutrality is also consistent with universal goals for any treatment. As I mentioned before, staying or leaving is an expression of free will and therefore their autonomy as an individual. And the goal of any treatment is to help one own their true desires and to be able to express them clearly to other people, because most life problems are interpersonal in nature, and being able to negotiate one's needs is important. If at the same time, if we try to convince our patient to choose one of the alternatives, we have an agenda, and therefore they would not be right and trust in us, which is especially true for those with a history of abuse or neglect in which another person did not hold their experience in mind. Neutrality, therefore, results in them seeking internal motivation for their decisions. And whatever that decision is, it's going to be right for them regardless if it is chosen freely and is coming from within, which the more they engage in that, it strengthens their own sense of identity, which is often impaired for those folks who are in the borderline range of functioning. Additionally, our neutrality is an expression of our certainty in their ability to make a decision. Therefore, we offer hope and allow them to experience their assertion, their aggression as the means for empowerment. And that helps with moving aggression away from the old bad category feeling that would otherwise be avoided. And so when we exercise therapeutic neutrality, we both exercise our libido and our aggression, because being invested in their choice and their ability to ask for what they need, regardless of how it affects their treatment with us or our desires or goals for their treatment, is an act of care, while pointing out inconsistencies in their behavior or promoting insight that might feel uncomfortable is an effective exercise of being aggressive as a clinician. Similarly, expecting more effort from them in treatment is an aggressive act, yet it's also a loving one, because it means that we see them as capable of more and we don't diminish or devalue them. More specific interventions have to do with strategic use of time. We can use timeouts, trial separations, or built-in breaks such as cancellations or holidays. People often need more time to think, and being alone can also give them that time, and also can function as emotion regulation strategy in and of itself. And so depending on whether they feel relief about not being in treatment versus longing and loss in the absence of treatment, they might resolve that ambivalence on their own. At the same time, it's important to put a limit of a time limit on the decision making, because that reinforces reality principle. Having an unstable sense of identity often makes it difficult to keep track of time, and therefore it creates a pattern of avoidance and lost opportunities. And reminder of the time passing curtails that avoidance and helps organize oneself to make a decision eventually. Also, containment of one's countertransference is an intervention. And containment doesn't mean suppression or denial of it. It's internal acknowledgement of one's countertransference and verbal expression of it in a safe, caring way. So what is modeled is the merger of libido and aggression as an empathic self-assertion and respectful negotiation of needs. And when needs are truly incompatible, it's not a sign of anyone's badness, it's simply, or goodness, it simply is an indication that there is not a match. And when there is not a match, it simply means that not all relationships are meant to last, or at least not in the form we expect them to. Also, we can engage in assertive ethical behaviors from the start, thus avoiding burnout and resentment later on, which often leads to unexpected abandonment after a period of excessive accommodation. So we can focus on getting informed consent, explaining the benefits and downsides of treatment alternatives, and therefore getting patients buy-in before the start of treatment, or alternatively, helping them find a more suitable treatment for them. Setting parameters of treatment at the start allows us to monitor our deviation from those and make sure that we are not extending ourselves beyond our limits. At the same time, it gives us an opportunity to explore their desire to change the rules of engagement after already agreeing to those conditions. When we recontract after those deviation, that is an opportunity to reaffirm clinicians' commitment to care, provided that the patient is engaged, which counteracts their fear of abandonment. And reestablishing treatment parameters throughout the treatment can be an effective use of aggression because it keeps patient accountable to their words at the start of the treatment, or makes it evident that they change their mind and no longer wish to participate in the treatment they sign up to participate in. Next, developing reasonable treatment goals prior to starting treatment. They should be able to express their desired outcomes in such a detail that we can observe and measure progress. We're keeping track of their treatment goals and progress towards them, which reinforces the idea that they're in charge of their treatment. They're the primary beneficiaries. We can be curious about the reasons for them not investing in goals they created for themselves, and lack of progress despite sufficient exploration demonstrates that treatment reached its maximum effectiveness and can be terminated. Reinforcing one's commitment to treatment agreements also reestablishes clinician as a trustworthy caretaker. While at the same time, when we expect progress to occur outside the session, we admit that we have limitations. We're not all good and all powerful. And we also place reasonable demands on the patient, which again is an effective use of aggression. Finally, order of priorities, agenda for the session. Those are informed by risk management. Any behavior that has the potential to disrupt the treatment, lateness, absences, any dangerous behavior has to be addressed first, because if there is no patient, there is no treatment. Anything that disrupts the relationship, gets in the way of productive collaboration, be it countertransference issues or ruptures, it gives us the opportunity to work on the treatment alliance, which is a common factor for treatment progress. Very important is to encourage the patient to express all of their emotions, including negative ones. And finally, any issues that are related to their treatment goals, things that brought them to treatment, starting with the hardest, because those are usually the indicative of where the areas of most growth are. So finally, in conclusion, I just wanted to give a summary of what can be useful. Paying attention to ambivalence as a diagnostic feature, establishing parameters of treatment at the onset, noticing and explore any deviation both by clinician and the patient, establishing clear, observable treatment goals, monitor patient's effort and progress towards those, establish order of priority, counteract avoidance, maintain a supportive but neutral stance with no investment in patient's decision, and monitoring our own deviation from neutrality. And remember that limits are as much an expression of care as they're an act of self-care. They ensure our ongoing engagement, protect us from burnout, and also demonstrate our trustworthiness and predictability to our patients. And at the same time, there is no need to exert extra effort trying to catch those who do not wish to be caught. We can catch and release. Sometimes our patients need to repeat the same pattern of disengagement several times in order to see that their ambivalent actions result in their own loss. And they might eventually learn from their experience if enough evidence is accumulated, because loss can be a great teacher. So I'm going to stop sharing.
Okay, thank you so much, Dr. Gvozdieva, right?
Yep.
This was such a wonderful talk, and I think a lot of clinicians are feeling that this is relevant for their treatment. We already have a few questions for everyone to note. This is the question and answer period. If you have any questions, please enter them into the Q&A section. If you'd like to ask it out loud, you can raise your hand, and then after the written questions, we can unmute you, so you will be able to do that. So, Dr. Gvozdieva, we already have a few questions for you. The first one comes from an anonymous attendee. Can you speak more about how patient dependency is fostered by the treatment or therapist?
So that relates to the part where the clinician becomes more directly involved in resolving patients' life concerns for the patient. So say someone presents for treatment, one of the goals they have is to become gainfully employed, and they do not make much effort of their own, and they ask clinician for some suggestions of how they are to go about looking for a job. And so in that way, the clinician now kind of steps into a role of seeking employment for the patient, who actually knows much better about what they're work history is, what their skill set is. And so the way, in a way, the patient depends on the clinician for reaching their goals, as opposed to the clinician encouraging the patient to become more autonomous and kind of serve as an outside consultant who encourages patient to take those steps towards goals that they have for themselves.
Okay,
And another possibility might be if a clinician is the one to tell the patient what is good for them versus not so good for them, right? Because we can only know what's good for us by engaging in introspection. Other people might have some ideas, but they don't necessarily know what is right for us personally.
I think that's a very clear answer about dependency. I have 2 questions from Lisa Cohen. These are in the chat. So I'm just going to read them to you. One is, could you please talk about an example from your caseload where ambivalence presented, how you brought it up to the patient, and how it was resolved?
I see ambivalence everywhere. And so as I mentioned, I often notice the discrepancies between what folks say they wish to achieve in treatment and what they tend to, the ways they tend to act in their treatment. And as I suggest to everyone, I usually present it to them as a difference between stated intent and observable action. And as I mentioned, sometimes folks kind of get into more self-critical stance, or they say, yes, I always do this. They kind of collapse in themselves, which then gives us an opportunity to explore what it's like for them when their own behavior, verbal and nonverbal, is presented to them, right? How they might feel ashamed of there being a discrepancy, which gives the opportunity for us to help them resolve it, right? And therefore get out of the shame spiral. There might be folks acquiescing and saying, yes, I will absolutely make the changes, but then usually it repeats again, and then we kind of slide into the previous pattern, which gives us more opportunities for ambivalence resolution. Other times that also gives an opportunity for the patient to just say, you know what, I don't think that goal is important to me. I do not wish to engage in treatment. This is not the time, not the place. I don't have the energy nor desire to invest in pursuing this treatment or this goal for myself. And then we have 2 possibilities. Either the treatment is terminated by mutual agreement, or we rework the treatment goals. And if we cannot come up with anything, then again, the treatment may be terminated. But if we can find a goal that motivates the patient internally to engage in it, then we're off to the races.
Okay, great. One more question, also from Lisa Cohen. Hi, Dr. G, great talk. Can you speak to the practice of neutrality with regard to not leaving therapy, but to stopping very destructive behavior?
Well, the neutrality would be to present the patient with a dilemma, right? And that they are engaging in a destructive behavior that has the potential to disrupt their treatment, which then the other side would be, do they really wish to be in treatment then? So there is an ethical concern there, obviously, in that if somebody is a danger to themselves, we must take necessary steps to keep them safe. At the same time, if the patient uses behavior that is disruptive to the treatment, that can be an expression of ambivalence. And so in that case, we kind of go back to square one, in which they're simultaneously wishing to be in treatment that they're trying very actively to disrupt. And that can be presented to them, and their thoughts on how those 2 things can occur simultaneously be explored.
Okay. While we're waiting for more questions, I'll ask one. And so this experience where you see the patient say they want one thing and then they act in contradiction to that, I think is a common one many of us probably see in therapy. Have you identified, or do you think about any other reasons other than ambivalence for that sort of contradiction to occur, or any other considerations for clinicians other than that?
Well, as I mentioned before, there are things that are truly outside of one control. So we might want things, but just not have the capacity to do so. But if it's something that if it's something that is not being acknowledged as one's being torn, or something that is not objectively outside of one's control, I tend to think that it has to do with the psychological processes in which the two sides of one's mind are not in talks. And so we might, the right hand doesn't know what the left hand is doing. And so we do one thing while saying another.
So maybe sometimes, and I'm just thinking of my patients here.
Yeah, please.
Sometimes it's not clear to the patient what might be an outside objective force that's impacting their behavior.
Oh, in what way?
For example, contextual factors, society, culture, but also ability, disability.
Well, right. So that brings us back to the idea of there being a way in which we regulate our emotions and our behavior given the circumstances, right? So treatment is something that is objective to the patient, right? There are parameters, there are time, we have scheduled appointments, we have, a time limit to a therapy session. They have our attention, but what it is that they do around those parameters is really up to them, right? And so we might be influenced by culture, but how we manage given that shared culture is very person dependent, right? So even within the same families, given the same, family structure, siblings might respond to the same parenting techniques dependent on their own unique personalities or their own understanding of how the world operates. And so the kind of the signature, the pattern in which the person engages with the culture, with the structure, with their disability, it really is something to be explored in therapy and understood.
That's great. That's really helpful. Does anyone else have questions for Dr. Gvozdieva? Just put them in the chat. You have a comment from Sydney Ortiz. This was wonderful. Thank you so much. Does anyone have a question, or would anyone like to say it out loud? And you can raise your hand and do that. I'll ask you, Dr. Gvozdieva, are you working on anything new right now, or is there a next focus for you after ambivalence?
Well, what I'm really working on these days is I continue to develop the intensive outpatient program, which is a big passion of mine. As you probably know, it's in its first year of operation, and we have plenty of opportunities to work with folks who are ambivalent, because it is a program that is short-term and rather intensive. And so any intensity often brings up those feelings, and that it might sound like a great idea to engage in 14 hours of therapy a week, but once one begins to exert that effort, it often feels effortful. And so we work with our folks on helping them make the decision between investment in their mental health or decision not to do so for the time being.
This plays out in lots of different settings. Yeah.
Yes. As I said, once you see it, you cannot unsee it. I tend to see it everywhere, including within myself. And so I find being able to think of it as just a part of human experience in which we kind of, want two things at once, want all of the things at once, and needing to compromise is very helpful.
You have one more question in the chat, and in the Q&A. This is from an anonymous attendee. Do you have suggested readings about ambivalence for further learning?
Well, I usually recommend Nancy McWilliams in the, I think it's called Psychoanalytic Diagnosis. She talks about borderline psychopathology and how it presents with a kind of, the split in an ambivalence. I'm a huge fan of Melanie Klein because she talks about libido and aggression and kind of this object relations theory. Otto Kernberg writes a lot about the split and various interventions that can help one work with the split in the psychotherapy.
The first one was Nancy McWilliams.
Yep.
Just putting those 3 authors in the chat for everyone, if you wanted to look those up. Okay, so it is 1 o'clock, so we are going to wrap up your talk for today. Dr. Gvozdieva, thank you so much for joining us today. And thank you, attendees, for coming as well and for your questions. Just a reminder, we are having psychology grand rounds on the first Friday of every month, except for July and August. So we are meeting again, actually June 14th is the next one at 12 o'clock. So thank you again for joining and have a good month, everyone.